Hello, I'm Pinakin Davey, a professor of optometry at Western University of Health Sciences, and it is indeed my pleasure to welcome you to this lecture series. Today we are looking at early detection of glaucomatous damage using new perimetric techniques. Everybody would agree that as far as glaucoma is concerned, early detection is the key. You detect a patient early, you intervene appropriately, manage the patient, and you can in fact change the natural course of glaucoma such that the patient would never reach visual disability. So look at the schematic. You are going to detect the patient early. You would intervene appropriately such that instead of their natural course of disease, they would actually slow the progression down and they would never reach the level of visual disability. Now, most of us would have actually faced this problem and a question, does structural loss always precede functional loss? And the answer to the question is, yes, that might be in theory. In reality, it's much more complicated. The ganglion cell has to die so that you can have visual field damage. But does the structural damage always precede functional damage? In fact, ocular hypertension treatment studies showed that 55% of patients that had ocular hypertension, no detectable damage, showed the first sign of conversion to glaucoma in optic nerve head pictures, whereas 35% of the patients showed using visual fields. Now, some might argue saying that, well, that was fundus photographs, we have better imaging technology today, and we should be able to do this job better. Well, let's look at some of that. Here's a picture from my prior publication. You can see these images of retinal nerve fiber layer plots that's plotted for 75 healthy patients and around 75 glaucoma patients. The blue represents healthy patients, the red represents the glaucoma patients. You look at this and say, well, at a glance, you can't even tell who is normal, which one was glaucoma and which one was normal. They look so similar. These are early glaucomas, mind you. Now, if you put them on top of each other, this drives the point home across very well. You look at this and say, all right, unless they were really, really super high and normal or really low and abnormal, you can't be sure if they are glaucomatous patients or they are normal. So even with OCT, detecting glaucoma in especially these early cases is going to be difficult. Octopus 600 has regular white and white perimetry, but has a specific perimetry called the Pulsar Perimetry. This Pulsar Perimetry, or the concept of Pulsar Perimetry, is to target specific ganglion cells. To understand this better, let's understand what does white on white perimetry do. So the standard automated perimetry has a white target on a white background, and so long as some ganglion cell is present and alive and kicking, the retina would say, or the human eye would say, I can see. So if you actually present the target on a patch of retina, and you could have three different options, parvo cells, magno cells, or conio cells, and so long as something's present, it's going to answer, yes, I can see. So in early pathology, white on white perimetry becomes slightly less sensitive. You think about pulsar perimetry, it actually specifically targets magnocellular pathway, and magno cells are far few to begin with, and in early pathology, it could detect glaucoma early. Let's look at pulsar perimetry stimuli. The pulsar perimetry stimuli is a ring-shaped pattern, black and white rings that are undergoing flicker, counterphase flicker, meaning the white ring becomes black and the black ring becomes white. When you have such a counterphase flicker that's occurring, the healthy eye would see a pattern like this, like a ripple. The patient that has early disease may not detect this stimuli. So the stimuli, the lower the contrast and higher the spatial resolution, it gets very difficult to see, and only healthy eyes can see it. And the greater the contrast and lower the spatial resolution, patients that have decreased vision can also see it. So one would expect that white on white perimetry, here your white on white perimetry on top, just shows early damage of paracentral scotoma, a nasal defect, whereas the pulsar perimeter shows a much larger defect when compared to white on white perimetry in the same patient. What are the other advantages and considerations with pulsar perimetry? The measurement technique of pulsar perimetry is more resilient to optical blur. So if the refraction or the lens that is placed is not absolutely perfect, it still can do a very good job of detecting appropriately. The outcomes are also more resistant to cataract and media opacities blur, which is very common in elderly population. It may be able to identify scotomas and disease early and shows much exaggerated damage when compared to white on white perimetry. It is particularly designed to detect early glaucoma or pretty much ocular hypertensive patients that you are thinking are so close and may be suspicious of glaucoma. This technique is absolutely perfect for that. When a person gets moderate to advanced damage, pulsar perimeter is not the best choice, and one should consider changing to white and white standard automated perimetry. Thank you.